Welcome to UMDF's Ask the Mito Doc monthly webcast. Tonight we will hear from Dr. Peter McGuire from the National Human Genome Research Institute in Bethesda, Maryland, and current member of UMDF's Scientific and Medical Advisory Board. Our moderator this evening is our very own Margaret Moore, UMDF Support and Education Associate. The floor is yours, Margaret. Take it away.
Hello, everyone, and welcome. Want to get started by thanking our sponsors, Edith L. Trees, UCB, and Astellas. We're always grateful for the support so that we can host webinars like this for you all. Want to bring your attention to our Give Energy program. If you know of any great businesses that you think would be interested in hosting a Give Energy campaign for us, please reach out at umdf.org/giveenergy/corporate-partnerships. Little housekeeping, please include any questions you may have in the Q&A feature on your at the bottom of your Zoom screen. If you have any questions for our technical questions about utilizing Zoom, please raise your hand and someone from the UMDF staff will help you. Closed captioning is available on all of our meetings. It is as simple as clicking either the little CC in the white box or the caption settings, and then you'll see another place to click the closed captions. Also, as a new feature, you have translation available. It's as simple as choosing the language that you'd like whatever we're saying to be translated to, and that will appear in the bottom of your screen. Nicole will be placing a link into the chat that gives more detailed information about utilizing our translation feature. So let's get started. Without further ado, I'd like to introduce Dr. Peter McGuire from the National Human Genome Research Institute.
Okay. There we go.
Hey there, Dr. McGuire.
Hello, good evening, everyone. Thank you so much for inviting me to talk. We are entering a challenging time of year, for individuals with mitochondrial disease, because it does become the cold and flu season. So tonight I'm going to talk a little bit about some of the things that we can look out for and do to help maintain immune health during this time. So let me just share my screen. There we go. Okay. And then. Okay, so I think we're all set.
I think you're ready to go.
Okay, it looks great. Okay, so thank you again. So today I'm going to be talking about maintaining immune health in mitochondrial disease. So before we start, I just wanted to mention, for those of you who are not aware, I'm an investigator at the National Human Genome Research Institute in Bethesda, Maryland. And here, as you can see in the picture, this is actually the NIH Clinical Center, where we conduct a clinical study, which is known as the NIH mini study, which stands for Metabolism, Infection, and Immunity in Mitochondrial Disease. So this is a natural history study of infection and immunity in children. We are pediatricians, so we see children with mitochondrial disease, where we look at things like their infection history and their immune function, as well as any disability which may have developed as a result of having a viral infection or because of their mitochondrial disease. So we are always looking for new participants. We've had a lot of families who have participated so far, and we are very grateful to them for their participation. There will be a link at the end for anyone who is interested in our study that they can contact us for more information. Okay, so viral infection and mitochondrial disease, there's this deleterious relationship, basically, or potentially deleterious relationship between individuals who have mitochondrial disease and viruses. So this is what we call host pathogen interactions, the pathogen being the virus, the host being the individual with mitochondrial disease. And so some of the things that we've actually noticed in our studies is that children with mitochondrial disease can experience recurrent infections, and up to 80% of them can experience these. And a lot of these are respiratory infections. So in other words, upper respiratory infections like upper respiratory symptoms like runny nose, cough, sneezing, earaches, and then also lower respiratory infections, things like pneumonia. And the issue with this is that it can actually cause something called metabolic decompensation. So in other words, kind of an acute deterioration in clinical status as a result of having this infection. And one of the unfortunate consequences of that is episodic neurodegeneration. So what I'm showing you here on the right is actually an MRI scan from an individual who experienced this kind of whitish area, which is indicated by the red arrow, are areas of damage in the central nervous system of this individual as a result of viral infection. So, for certain individuals with mitochondrial disease, this is something that is of concern and is something that they think about as we go into the cold and flu season. So we're going to talk about, some of the things that we can do in recognizing some of the symptoms and signs of these things and some of the steps that we can take. So I mentioned metabolic decompensation. This is essentially an acute deterioration in the status of an individual with mitochondrial disease, and it can be life-threatening. It results from bioenergetic failure. So in other words, the mitochondria kind of push to their limits and can no longer keep up with the requirements of an infection, because infection, as you would imagine, is a very energetically expensive process. It requires a lot of energy from the body to be able to fight it. It can result in lactic acidosis. As I mentioned, you can have disease progression, organ problems such as liver problems, encephalopathy, so problems with the central nervous system. These metabolic strokes, which is the picture that I just showed you before, where they have death of neurons in certain parts of the brain as a result of infection. And many times individuals are left with complications afterwards. So complications are known as sequelae. So complications afterwards, which can be pretty life-changing and can change, activities of daily living and various aspects of their disease. These individuals can require extensive ICU care. And one of the most common causes is infection that actually leads to these episodes of metabolic decompensation. And we don't, at this point, really have any magic bullet for this. The treatment is really symptomatic. So infection, some of you may have heard me talk about this before, infection is inevitable in children. I mean, sooner or later, children are going to encounter an infection. And part of it has to do with their immune system. Their immune system is still in the process of developing. So they are at younger ages prone to getting infections. And this is kind of what I'm showing you here. So this is a study of young children with asthma. So this is from the Copenhagen Prospective Study on Asthma in Childhood 2000, or COPSEC 2000. And it's a prospective cohort. So what that means is they follow the children from birth up until about 3 years of age. And it was about 411 children that they followed. And what they found was that children on average in the first 3 years of life experience somewhere around 13 to 15 infections in the first 3 years of life. A lot of these infections are respiratory tract infections, as you can see here in B. Basically, these occur primarily during the winter season, as you can see here in the bottom graph. So this is something that obviously individuals with mitochondrial disease are very aware of. They know when flu season is, and they are on alert, and may even kind of change their behaviors during this time to try and mitigate some of the effects of infection. So the primary organisms that we're concerned about during this time of year are really viruses. So viruses are submicroscopic infectious agents. And viruses, the interesting thing about viruses is they infect all life forms. So there are viruses for plants, there are viruses for animals, there are viruses for humans. And one of the things that they share in common is that viruses are not really considered to be living, because they actually, one of their characteristics is that they actually require a living cell to replicate themselves. They don't have the machinery within themselves to replicate. They have to use a host cell to replicate. So they infect host cells and they replicate within that host cell. Another common feature is that viruses contain a core material, and that core material is either DNA or RNA. Most of the viruses we're going to talk about today are RNA viruses, which cause kind of upper respiratory tract type infections. That DNA or RNA can be covered by a capsid, which is kind of a protein coat, and then that can be covered by an envelope on the outside. And these different viruses, as you can see, are on the right. They come in all different shapes and sizes. Some of them have, things on their outsides like spikes, which we've heard about in coronavirus. But they basically have these common features, which I mentioned, but can come in different shapes and sizes. So one of the things that's very important for viruses is antiviral immunity. So in this particular cartoon, I'm just kind of summarizing, what do I mean by immunity? What happens when our body encounters a virus and we try to fight that virus? So here I'm using SARS-CoV-2 as an example, but basically one of the first thing that happens is there is an innate immune response to the virus. So in other words, there are cells that basically eat up the virus and then activate the immune system, and these are known as dendritic cells. And part of that activation involves the activation of adaptive immunity, or the induction of adaptive immunity. So these are T cells and B cells. T cells are important for killing virally infected cells. They're important for coordinating the immune response, as well as activating B cells. Now, the reason B cells are important is because B cells can form plasma cells. Plasma cells are essentially an antibody factory. They make antibodies, which they secrete into our bloodstream, and these antibodies can block virus or actually kind of neutralize virus or do many different things to viruses to prevent them from infecting or to kind of mitigate the effects of infection. So one of the things that's important about encountering a virus or even vaccination is the development of memory, so immune memory. So here on the right in panel B, you can see that when we talk about an infection, so this can be either infection or vaccination. We can use the two kind of interchangeably. And you can see that when an infection occurs, the virus, the amount of virus, which is in purple, kind of goes up very quickly over about a week or so, and then eventually drops. And during that time, you're having this immune activation that goes on your left, like I mentioned. But one important part of that is that specific antibodies start to rise in about the middle of the viral infection, and then they can persist over time and drop off. At the same time, you have the development of immune memory. So memory B cells and memory T cells, which can persist actually for months and for years. Memory T cells are important for recognizing the virus again and reacting very quickly and killing virally infected cells, whereas memory B cells are important for recognizing the virus again and making antibodies. So B cells also form, as I mentioned, they form these plasma cells. These plasma cells can actually also sit in the bone marrow and make antibodies that they excrete into the blood on a daily basis. And this is what we refer to as antibody titers. So that's why you see the blue line here, these specific antibodies for this virus can persist for months and even years. And even though over years they're at low levels, they are enough to offer protection from this initial infection or vaccination. So one of the things that we noticed was that kids with mitochondrial disease tend to have a very different relationship with infection. In other words, when they encounter infections. So this is a study that we did recently that we submitted for publication, where we looked at how many viral exposures an individual would have. And we made this hypothesis or this prediction that as they got older, the number of viral exposures would increase. So it'd almost be like a linear relationship, like I'm showing here on the right. So when we looked at individuals who do not have mitochondrial disease, which is here in blue, you can see that their exposures, their number of viral exposures kind of forms a straight line here, or kind of centers somewhere around this line. So there seems to be a relationship between in individuals without mitochondrial disease, that as they get older, they have more viral exposures or more viral infections or encounter more viral infections. When we look at kids with mitochondrial disease, we don't see that relationship. You can see the line here in the middle is more straight rather than going, up to the right, off to the right. And that kind of, and so what that tells us essentially is that kids with mitochondrial disease experience viruses or have viral exposures very differently than kids who don't have mitochondrial disease. And part of that is because a lot of them tend to have more viral exposures at a younger age. So you can see here, some of the kids who are younger than 5 are having 15, 17, and 20 viral exposures under the age of 5, where that number tends to be lower in children who don't have mitochondrial disease. So basically what these data are saying is that kids with mitochondrial disease experience viruses in a very different way. They tend to get more viral infections at younger ages. So what types of viral infections are they? So once again, this was looking at patients with mitochondrial disease. And I didn't mention that was 16 patients and 16 control children. And they were about 6 years of age. So these are some of the viruses that they actually are exposed to. So this was a study that we did recently, which we just published during the COVID-19 pandemic, where we looked at all the different viruses that children with mitochondrial disease, that's what MTD stands for, and family members were exposed to during the COVID-19 pandemic from 2020 to 2021. So basically, it was 19 different families that we, were able to look at. And 19 different families that we're able to look at, and we were able to catalog the different viruses that the child with mitochondrial disease was exposed to and other family members were exposed to. And we were able to compile this basically hit list, this top 10 hit list. So FAM means family member, in other words, what viruses they were exposed to. MTD means mitochondrial disease. And then shared means the virus that in a single family, the child with mitochondrial disease had that virus and a family member had that virus, which suggests potentially transmission from family members to the child with mitochondrial disease or vice versa. So the most common viruses, as you would imagine, are basically respiratory viruses and diarrhea viruses. So, so diarrhea viruses meaning enteric viruses. So things like enterovirus B, enterovirus C, enterovirus A, enterovirus D. These are all kind of bugs or viruses that cause gastrointestinal upset and things like that. Whereas these other viruses like rhinovirus, A and B, influenza B virus, RSV, mass adenovirus, and SARS-related coronavirus, these are upper respiratory tract infection type of viruses. So not only was enterovirus B the most common virus in family members, about 23% of family members and 53% of children with mitochondrial disease, but it turned out this was also a virus that was shared fairly often within the family between the child with mitochondrial disease and at least one other family member. And that was about almost 30% of the time that these viruses were shared. And that, that kind of tells us something. So first of all, enteroviruses are very, very infectious. They tend to pass through families pretty easily, pretty quickly. And one of the ways, since it is an enterovirus, in other words, an enteric virus that causes vomiting, diarrhea types of illnesses, one of the best ways you can protect yourself is from hand washing, essentially hand washing and not sharing things like utensils and glasses and plates and toothbrushes and things like that. So these is basically the common viruses that children with mitochondrial disease are infected with. It turns out that these viruses are no different than viruses that children without mitochondrial disease actually are exposed to. So these are common viruses, basically. So one of the other things we looked at is how strong was the antibody response to these common viruses. So as I mentioned before, B cells form antibodies. And B cells form plasma cells after coming in contact with virus. And then these plasma cells go to the bone marrow and eventually make antibodies which contribute to the circulating antibodies in our blood. So these are known as titers, antibody titers. It turns out that in mitochondrial disease, it may be that these plasma cells that live in the bone marrow, they're called long-lived plasma cells, don't survive as long. So therefore, the amount of antibody that they're actually pumping out to protect you against viruses is less. And we actually see that when we look at viral proteins. So this is from 16 children, control children, and then 16 children with mitochondrial disease. And if you look, what we're looking at is different viral proteins and the amount of antibody essentially that is binding to those viral proteins. And you can see in general, the lines are essentially going down. They're going down to the right, which means that children with mitochondrial disease have less numbers of antibodies to the same viral proteins. So this means that their antibody responses, or their antibodies floating around in the blood, there are less of them. They're less robust. And therefore, that can be a problem with protection against viruses. So also in our study, which we did during COVID in 2020 and 2021, is we looked at different illnesses that individuals developed over the course of that year and hospitalizations. And during that time, we basically had, this is a busy slide with a busy table, I understand that. But I just wanted to show that just to show the amount of data that we actually collected and really looked very hard at these patients individually to kind of see what their outcomes were after having viral infection. So we had essentially like 6 hospitalizations. Of those, I think 4 went to the ICU, and I think 4 actually had neurologic complications afterwards. And that unfortunately is one of the things that can happen with viral infection. But one main takeaway, which is kind of an easier message to digest, is that when we looked at the IPMDS score, so the International Pediatric Mitochondrial Disease Scale score, which a higher score means more symptoms of mitochondrial disease, the higher score you had, the more likely you were to be hospitalized. So in other words, if your mitochondrial disease is worse on the IPMDS score scale, you are more likely to be hospitalized. So these are some things that we learned during COVID, but this is a new year now, and there is something else kind of brewing on the horizon. And so actually it's not brewing, it's ongoing right now, which they're calling the triple-demic. So this is you may have seen this in your local newspaper or various news outlets, but basically the triple-demic refers to the current season now, where we have flu, RSV, and COVID kind of co-occurring at the same time, and are basically, especially in the pediatric population, causing a lot of admissions to hospital, and hospitals are overflowing, especially the pediatric units. So this really, tells us about the seasonality of these viruses. So we are exposed to viruses all year round, basically. So things like adenovirus or bocavirus, these are things that you're exposed to all year round. But the time that we're entering right now, which is in the box up here, the dashed box, we have influenza virus, coronavirus, and RSV. So this is the triple-demic that they're talking about. So what I want to do for the remainder of the talk is I want to tell you about each of these viruses, some of the symptoms, the diagnosis, what we can do to help for treatment during these episodes. Okay, so the first one is influenza virus. So this is a graph showing the number of influenza positive tests from May 22nd up until November 5th, so last week. So this is data from the CDC. So the way that the CDC actually collects these data is they collect it in 2-week periods. So the next data set will be out around November 19th. So this is current as up until last week. And so what you're seeing is that during the summer months, there was this dip here in influenza. But now we're coming into the fall season, we're into November already, and you can see that influenza is starting to spike again. The other thing that this graph tells you is the different types of influenza. So there's influenza A, B, and C. A and B are common types of influenza. And basically, you can see here that basically what we are seeing is influenza A seems to be the predominant strain that is circulating at the moment. If you're curious about where you live in particular, this is a map of the United States, and this also is from the CDC website. So I should point out, for individuals with mitochondrial disease and caregivers who are concerned about flu, the CDC maintains a really good website known as FluView, which you can actually get a lot of information about the flu, about diagnosis, about treatment, about vaccination, as well as the number of flu cases in your area, hospitalizations, what age groups are being affected. So it's a very helpful website for having information. So this is a map of the United States, and you can see here ILI stands for influenza-like infection. And this is the activity level across the United States. The more purple, or reddish to purple, is very high. And then when you're down in the green area, it's minimal. But influenza tends to move across the country. So we're probably at an early stage here with regards to the East Coast. It also tends to reflect population density as well. So places like California, for instance, which have high population densities, as well as the East Coast, as you would imagine, would get hit pretty hard. So you can see here basically a lot of red and a lot of purple, indicating a lot of influenza-like activity or like illnesses across the United States at this time. So influenza is on the rise now. We are in influenza season. Influenza vaccination is available right now, and I would encourage you to get that, and we'll talk about that in a minute. But I want to tell you just a little bit about influenza itself, and just to kind of educate you a little bit about this virus and how it kind of works. So this is kind of the infection cycle of influenza. So influenza, as we mentioned before, right, they have nucleic acid inside. So in this case, it's RNA. So they have RNA inside. It's contained inside this shell, which has proteins on the outside, hemagglutinin and neuraminidase. And what happens is, as I mentioned, viruses are not considered to be living things. They have to use a host cell to reproduce themselves. So this is a very complicated picture, but I'll just walk you through it very simply. So basically, influenza, the influenza virus, has to attach to the host cell, and it does that basically on a host cell receptor. And these are host cell receptors that actually have sialylated residues. So these are residues that are recognized by the influenza virus, the hemagglutinin, which binds to it. And when it binds to it, then the influenza virus gets taken up into the cell. And within the vacuole that it is in, basically you have acidification, so the pH changes, and then the virus essentially releases its viral genome, in this case RNA, into the cell. Now, the reason it does this is because the viral RNA has to be replicated, because if you're going to make more virus, you have to replicate that RNA. And then the other thing is the RNA is going to be used to make proteins, because there are proteins on the surface of the virus that have to be made, and other internal proteins that have to be made that help the virus essentially function and then allow it to infect other cells. So you replicate the RNA, you replicate the RNA, you make proteins for the inside of the virus as well as the surface of the virus, and then you package the whole thing again back into by essentially this budding here, where it is coated with these viral proteins that you've made, and the virus essentially exits the cell, and now it can go and infect another cell. And I know this is showing this basically showing a single virus, but you have to think of this in a much larger scale. I mean, the amount of viruses that infect single cells can be, you know, in the thousands to hundreds of thousands. It depends on the virus. But what happens to the cell as a result is that eventually the cell will die from this process of viral replication. So what are some of the symptoms of influenza? Many of us, of course, are very familiar with the symptoms of influenza. You can have things like neurologic signs like fever and headache, as well as maybe some confusion. You can have a dry cough, a sore throat, nasal congestion, so respiratory type symptoms. It can also cause gastrointestinal symptoms. Many people don't think about that too often, but it can cause nausea, vomiting, and diarrhea. Musculoskeletal symptoms like muscle aches and fatigue. Some of the complications that can happen febrile convulsions. So some children can experience actually seizures as a result of having fever. Rye syndrome is something that we don't see as much anymore. That was a combination of having influenza and taking aspirin at the same time. So that's why they advise not to take aspirin specifically when you have an influenza-like illness. Other things that can happen are meningitis or encephalitis, so in other words, infection of the brain. Transverse myelitis, so it can affect the spinal cord. Guillain-Barré syndrome, which is a type of paralysis which can result from infection. You can also have effects on the heart, such as inflammation of the heart, pericarditis, myocarditis, exacerbation of if the individual has underlying cardiac compromise that can be exacerbated in influenza. Some other respiratory complications, earaches, basically, croup, so that kind of barky seal-like cough. It sounds like a barking seal, essentially. Sinusitis, bronchitis, pneumonia, exacerbation of lung problems. And then also, once again, there's some pregnancy issues, but also musculoskeletal stuff such as inflammation of muscle and breakdown of muscle. So how is influenza actually diagnosed? So it is a multi-tier process, as you would imagine, when you go to visit your doctor. So one of which is physical exam. So it's to identify some of the features of influenza and kind of raise the suspicion that influenza-like illness is occurring. And then testing. So there is a rapid influenza diagnostic test, which involves a swab, and it usually involves antigen testing. There's also molecular testing that is usually can be available in a couple of hours. And that usually involves something called PCR to test for the viral nucleic acid. There's also viral culture. That is usually not done. It's only done in situations where they're looking for a specific viral strain, as is serologic testing. In other words, testing for antibodies against a virus. That's generally not done. That's more done on the public health level, where they're actually doing surveillance for different viruses. So if you go to your doctor, the two most likely things you'll probably experience are the rapid influenza testing with the antigen test, or the rapid molecular testing with the PCR. So how do we treat influenza? So first of all, we want to prevent the spread of flu, right? So in other words, within households, especially for individuals who have mitochondrial disease, if it turns out that there's another household member who has the flu. And one of the ways you can do that is by avoiding contact. So once again, in the household, like keeping away from other individuals. As far as going, leaving the home or going to school or things like that, it's advised that if you have flu-like illness, that you stay home for 24 hours after the symptoms disappear. You want to disinfect and wash your hands, because hand washing is a very effective way to prevent infection of other individuals. You want to avoid touching your eyes, nose, and mouth because germs can spread this way. And then also sneezing, right? You want to cover your nose and mouth when you're coughing or sneezing. You don't want to leave tissues around. You want to make sure you throw them away. For younger kids, an easy way to help them with this is when they're coughing or sneezing, you say to do it into their elbow. That's an old pediatrician's trick. Treatment for influenza, one of the other treatments, a lot of it is symptomatic care, treating the fever with, medicines to reduce the fever, drinking a lot of fluids, et cetera. But vaccination is one of the best ways for actually prevention. So every year, the World Health Organization gets together with numerous agencies to look at the circulating flu viruses for the year. And based on what they see, they then make recommendations for the components of the flu virus, the flu vaccine, excuse me. And the way the flu vaccine works, if you remember from before, if you are here it says first infection, but we can just say injection or vaccine. You have activation of B cells. B cells make antibodies, and these B cells and antibodies persist so that when you are exposed the second time, you have a more robust response, and you make antibodies you have a greater production of antibodies at a much quicker time scale, essentially. So this is essentially how vaccination works. And vaccination efficacy does change from year to year, and it depends on a number of things, one of which is how accurate was the World Health Organization in terms of the circulating influenza strains and predicting, which strains should go into the vaccine. As well as the fact that influenza viruses actually change every year because their proteins, which are recognized by the immune system, undergo mutation, and that actually changes the virus and how it's recognized by the immune system. So that's why it is very important to be vaccinated every flu season. Okay, so how does this work? We make these antibodies, these B cells, these plasma cells make these antibodies. How do they actually work and protect us against infection? So basically, they bind the virus. They bind the virus and prevent the virus from entering cells and making more virus. So you can see here, these red antibodies are binding to the virus. It's kind of preventing it from actually getting inside the cell. If it does get inside the cell, there are even antibodies that can prevent the virus from fusing and releasing its RNA into the cell. Another way that antibodies can be useful as well is it prevents the virus release from the cell. So after you replicate the RNA, you make these viral proteins, you start to put the whole package together. Antibodies can actually prevent this virus from budding off of the cell and then basically reducing the amount of virus that's released that then can go and infect other cells. A couple of other ways that antibodies work is that they can actually recognize viral proteins that are on the surface of cells, right? Because the virus has to assemble using these proteins. And what that is that's a sign for the immune system to come and kill this virally infected cell. So if you shut down the factory and kill the cell, you can't make more virus. So that's one of the other functions of antibodies. So antibodies are very important, and vaccination is an important part of this whole equation. So another treatment for influenza, and all these things that I'm talking about, obviously for individuals with mitochondrial disease, you should discuss this with your healthcare provider. But one of the important treatments for influenza, especially in the early part of the disease, so this has to happen within about the first 2 days of having symptoms, is you can take certain drugs that can help basically with influenza infection. So the ones that are there are a lot of different drugs on here, but the ones that are really available and used clinically are these neuraminidase inhibitors. So oseltamivir, there's a lot of different zanamivir, all these different drugs are basically neuraminidase inhibitors. So what they actually block is this attachment of the virus by hemagglutinin to receptors on the cell surface. So if they can't attach, the virus cannot enter a cell and replicate. And therefore, you are basically reducing the virus's ability to replicate by basically inhibiting its ability to bind to a host cell. So these, as I said, are available clinically. They are available under prescription from a doctor and are most effective if taken within about the first 2 days of presentation of symptoms. Okay, so that was influenza. The next we have is SARS-CoV-2. So I know, we've all been hearing about SARS for the past 2 years now, and I'm sure everyone's really tired of it. But it is still around, and individuals are still getting ill from SARS-CoV-2. This was as of yesterday. So, worldwide, we have over 635 million cases, but things have changed because, vaccines are available. And the recent bivalent boosters, which I'll mention, have become available as well to handle the Omicron BA4 variant, as well as some of the original variants. But this is a very different picture than where we were 2 years ago, where we had rising cases, but we had very little in our arsenal in terms of approaching this illness. But now we do have vaccination. So everyone knows SARS-CoV-2 is a coronavirus. It stands for severe acute respiratory syndrome coronavirus 2. It is this particular virus, it's 3 years into it now. It was a new virus, although it was related to other coronaviruses, such as the common cold, SARS back in 2003, or MERS in 2012. They're all related, they're all coronaviruses, but this one was new, essentially. And the genetic evidence suggests that it actually started in animals, somewhere in the Wuhan region of China. And COVID-19, of course, means coronavirus disease 19. So once again, as a virus, it basically uses very similar mechanisms, just like flu, to replicate, right? So as we said before, viruses are non-living and have to use host cells to be able to replicate. So in this particular case, the coronavirus, which has on its surface these proteins, spike protein, binds to a receptor on the cell surface and these are cells lining your respiratory tract. And this particular receptor is known as the ACE2 receptor. So this is what it uses to gain entry into the cell. Then it fuses, it's in a vacuole, and then it fuses and releases its RNA, and then the RNA is replicated, and then the virus is reassembled again because proteins are made, and it buds off. It looks exactly like what happens with influenza, right? There are some details which are different, but in general, the process is basically the same. So what are some of the symptoms of COVID-19? So for individuals who have been spared from actually experiencing COVID-19 during this time, but are probably still familiar with a lot of the symptoms, it's fever, it's cough or sore throat, shortness of breath, chills, muscle pain is a very common, muscle pain and headache are a very common one. Something that's kind of unique and defining to COVID-19, as we all have learned, is this kind of loss of taste or smell. It's really smell, because the smell and taste kind of go together. So it's this kind of change in smell or loss of smell. They can also have vomiting and diarrhea. Headache, as I mentioned, is a very common presenting feature of COVID-19, as well as congestion, runny nose. So you could have all of these, some of these. It really depends on the individual. Children who have neurodevelopmental disorders like mitochondrial disease, in general, we have a increased concern over, some of the of having viral infections, because they are more prone to having adverse outcomes from viral infections. For COVID, though, we have not heard, we have heard of a few cases, and we have reported a few cases of adverse outcomes, but in general, the pediatric mitochondrial disease community, which is a community that we take care of, for the most part, actually have done reasonably well with COVID-19. These are some of the manifestations of severe COVID-19, acute respiratory distress syndrome. You can have injury to the heart, injury to the kidneys. There are neurologic disorders and something called long COVID, which can persist after COVID has resolved. In children, you can have this potential hyperinflammatory syndrome known as multisystem inflammatory syndrome in children, or MIS-C. These features all speak to the fact that inflammation is playing a major role in this disorder. And so what is inflammation? Inflammation is essentially, it's a normal immune response to infection, and it helps clear the infection, and involves essentially white blood cells, which secrete these things called cytokines. But the problem is, these cytokines, which I like to call text messages, these are small little proteins or peptides that cells use to communicate with each other. So that's why I call them text messages. But what happens is that you could have something called cytokine storm, where you're making too much of these text messages in great abundance. And this can actually be damaging to certain organ systems, such as the heart, the kidneys, the lungs, the brain, etc. So this is basically this severe reaction to COVID is really what we call cytokine storm, or overactivation of the immune system and really requires responds to immune modulating drugs such as steroids and things like that. So the diagnosis for COVID, as we all have learned over these past 3 years, now there is the availability of rapid antigen testing at home. So I'm sure a lot of individuals on this call have done a home test at some point or have home COVID-19 tests in their house at this moment. But once again, this is antigen testing, similar to flu. There's also a PCR base, so this takes a couple of hours. You can do this at your physician. And then there are also other enzymatic serologic tests that can be done for COVID. So the treatment for COVID, you have symptomatic treatment, but of course, the one thing that has been most beneficial in terms of COVID-19 and the prevention of adverse outcomes has been vaccination. So at this point, we are now in the phase where there is a booster dose, and it is a bivalent booster dose. So what I mean by bivalent? So it is a dose or a booster dose that is effective not only against the original strains of COVID-19, but against one of the new Omicron strains that is circulating. So booster doses are available now and are encouraged for individuals to help prevent severe manifestations and outcomes as a result of having COVID-19 infection. As far as some of the treatments that can be employed before the hospital or in the hospital, there are various drugs. So there are monoclonal antibodies and things like convalescent plasma. So in other words, plasma from individuals who have been exposed and have antibodies against COVID-19. There are also antivirals. Remdesivir is one of the antivirals. For individuals who are in the hospital, as I mentioned, inflammation can be a big problem and can be damaging to various organ systems. So in which case things like corticosteroids or steroids can be very helpful in reducing that inflammation, as well as other anti-inflammatories. So the idea, though, is with vaccination, though, we won't have to get to this point of hospital management and treatment. There is also a medication that is currently available that individuals can take at home, which is known as Paxlovid. So Paxlovid is a drug basically that blocks a protein that the virus actually uses to replicate itself or multiply. And the current indications are, you have the current indications are basically for kids who are 12 and older, who are 88 pounds and more and are at high risk. And it lowers the risk, by almost 90%. So it's quite, quite effective. It's quite expensive too. So, but this is a drug that can be quite effective against mild to moderate COVID-19. And it is currently only available by prescription only. So if this is something that is, considered by either a caregiver or an individual with mitochondrial disease, it has to be in consultation with a physician. Okay, so finally, RSV. So this is the third part of the triple-demic, and this is respiratory syncytial virus. This is also another RNA virus. All the viruses we've talked about this evening are RNA viruses. So there is actually surveillance. So this is also from the CDC website. There's surveillance of RSV. And as you can see, we're actually experiencing a spike in hospitalizations as a result of RSV. So here it shows RSV over the different years, and each of the years are color-coded. And you can see what we usually are starting to see spikes around, December or January or so. What was this? This was 2019, 2020. It was around, December, January, pretty much the same for 2018, 2019, but we're seeing an early spike this year, in hospitalizations as a result of RSV. And it is co-occurring at the same time, of course, with influenza and with COVID. Now, the RSV life cycle of this, virus is very similar, right, to what we saw. So in other words, they're not living things. They need a host cell to replicate. So in this particular case, the virus actually, once again, fuses with the host cell. It releases its, nucleic acid. There is, viral DNA synthesis, and then protein synthesis. And the idea, once again, is to repackage this virus and release it so basically that this virus can infect other cells. So once again, we're talking about, even though I'm only showing, kind of a single virus here in a cell, we're talking about, potentially thousands of, viruses, within a cell doing this all at the same time. So what are some of the symptoms of RSV? So in older individuals, RSV can kind of look like the common cold. You can have things like, runny or stuffy nose. You can have coughing, fever, some wheezing. So individuals, especially individuals who are prone to reactive airway disease or asthma, can have an exacerbation of that illness as a result of having RSV. Some individuals can have difficulty breathing, difficulty feeding. That tends to refer more to younger kids. So RSV is, while in older individuals can produce kind of cold and flu kind of symptoms, in younger individuals actually can be quite severe, because in babies, their airways are a lot smaller. And when they get an RSV infection, they can actually have swelling inside and inflammation from the RSV, and it can cause severe disease. So here on the right, I'm showing a chest X-ray of a child, of a young child with RSV pneumonia. And basically here in the middle, this big blob here is the heart. And up here on the right, this is sorry, it's reversed. So this is the right. So up here on the right, you can see there's a dense area here. That's actually collapse. That's actually lung collapse. And then you can see all this kind of streakiness inside the lung. This is severe RSV disease. And it's young children or children with underlying respiratory disease or underlying lung disease are at risk for adverse outcomes. And there is an outbreak of RSV now where the pediatric hospitals are becoming full with these cases of children with RSV. So how is RSV diagnosed? Once again, similar types of testing. There is a rapid antigen testing, which is available within, minutes, and then the PCR testing, which is available within hours. And then there's also other laboratory testing that can be done. The treatment of RSV, so in general for, kind of older children, it's managing fever and pain. It's using things like over-the-counter, acetaminophen or ibuprofen. Now, this has to be, in consultation, obviously, with your physician, because some kids with mitochondrial disease have problems with their kidneys, so ibuprofen won't be good. And some kids with mitochondrial disease have problems with their livers, so therefore acetaminophen might not be good. So this should be done in consultation with your physician. Always drinking enough fluids. And this, these kind of general guidelines apply to any type of, viral illness that you will experience during this season. So making sure to drink a lot of fluids to prevent dehydration, because fever requires a lot of energy, and you actually lose a lot of bodily fluid as a result of having fever. And then also communicating with your healthcare provider, especially when you're talking about, things like cold medicines and things like that, because, some cold medicines will contain ibuprofen and acetaminophen or Tylenol and Motrin, essentially, are what these two are. And you don't want to kind of double up on the dose, because some of these cough and fever medicines actually do contain Tylenol and Motrin as well. So another treatment for RSV, so this is something that is generally reserved for children who have a chronic lung condition. So this is something called Synagis. So Synagis is essentially a type of engineered antibody that is actually given during RSV season to individuals who have a very specific type of diagnosis. So individuals who are eligible to receive Synagis treatment during RSV season. By the way, it's an injection also too, that individuals would do at home. They have to be born premature at or before 35 weeks, who are 6 months or less at the beginning of the RSV season. They have to have a chronic lung condition. So bronchopulmonary dysplasia is a condition that develops in certain individuals. Usually they spend a long time in the NICU and have breathing problems and may require assisted ventilation for a while, and have an abnormal kind of formation of their respiratory system. And then other individuals are individuals who have certain types of heart disease who are 24 months or less at the beginning of RSV season. So once again, this is a treatment that is available for a very select group of children who tend to have underlying lung disease, usually from birth. And so if this is something that if your child fits into this category, this is something that you should discuss with your provider in terms of risk for adverse outcomes for RSV. Okay, and then some of the precautions are similar to what I mentioned before. RSV is an upper respiratory virus. It is passed on surfaces. It's passed by sneezing and coughing and things like that. So some of the things you want to do are wash your hands often. And there are good websites about hand washing where you should do it for at least 20 seconds, using soap or using an alcohol-based hand sanitizer, not touching your face, right? So these are all similar recommendations like we heard before. Avoiding close contact with sick people, sharing utensils, sharing cups for individuals who are sick, as well as kissing. Covering coughs and sneezes, as we mentioned, for the younger kids, using the elbow or telling them to cough or sneeze into their elbow is something that's very helpful because young children are less adept at covering their mouths with their hands. So using the elbow is very helpful. Also making sure to throw away tissues in the trash afterwards. It seems kind of obvious, but you'd be surprised. And I'm sure there's some people on the call who have found trails of Kleenex from an individual who's been sick in their home. Clean and disinfecting surfaces is important because surfaces can, serve as a conduit for viral infections, and that includes things like toys, doorknobs, mobile devices. These can be very important things that you don't really realize that individuals are touching all day long, including children. And then staying at home when you're sick, not going to work or school or public areas, and this helps prevent spread of your illness. So in summary, so we're entering now the kind of cough and cold season, the flu season. It is, this triple-demic seems to be going on now. We've talked a little bit about the different viruses and how they're, how they work and how they're diagnosed and some of the treatments that are available. In general, I mean, viral infections are inevitable. As we mentioned, that children will, because of their developing immune system, develop viral infections at some point in their life. It turns out that kids with mitochondrial disease tend to develop, the timing of their viral infections tends to be a little bit different than children who do not have mitochondrial disease. They tend to get infections earlier in age. So one of the ways that we can help maintain our immune health during this season, within reason, in terms of an individual's mitochondrial disease, would be things like exercise, eating healthy diet, minimizing exposure. So that means minimizing exposure to other individuals, either inside or outside the home, and that can include, keeping individuals away as well as masking. Vaccination is an important part. Of the triple-demic, there are vaccinations available for 2 of those 3 viruses, essentially, for influenza as well as COVID. And that's an important part of preventing severe outcomes from those viral infections. And then there are specific drugs, depending on the viral infection, there can be specific drugs that are available, but all of this, of course, is done in consultation with a medical provider. And as I mentioned, there is the triple threat this year of these 3 viruses. And individuals with mitochondrial disease and caregivers with mitochondrial disease are very aware of this. They've been aware of this for a long time, and tend to practice behaviors that help them avoid infection. But it's always good to remind ourselves of some of the things that we need to do to try and minimize the risk to individuals with mitochondrial disease and help them maintain their health. So I wanted to thank everyone for, or thank the organizers for a chance to come and speak with you tonight during this cold and flu season, and I'd be happy to take any questions.
Thank you, Dr. McGuire. That was a wonderful presentation that I just know our families are going to refer back to over and over again. We do have quite a few questions, and if you're willing to hang on, we will try to get to some. I have reviewed them and kind of have a different order that I want to ask them in. Okay, so our very first question was about, is it okay for a mito patient on IVIG to do the IgG infusion while they are sick with the flu virus or have an infection?
Is it okay for them to do that? Yeah. Right. So first of all, so IVIG. So what is IVIG, right? So it is essentially pooled immunoglobulin or antibodies from anywhere between like 10 to 100 people, right? So these are antibodies that are quite diverse in terms of their ability to recognize different viruses, right? Because you're getting it from a whole bunch of different people who have, and they're normally adults, right? So adults have a lot of different exposures during their lifetime. So it can be quite helpful or protective. So what I would say is that's a question that needs to be discussed with the immunologist or the neurologist who's doing the infusion. But what I can say is the antibodies that are in that infusion are actually quite good for protecting or resolving infection. So just as an example, back in, 2009, when we had the H1N1 pandemic, right? Influenza pandemic back in 2009, one of the treatments that they actually used was actually immunoglobulin. So in the ICU for severe individuals, they actually used immunoglobulin therapy to help those individuals during a overwhelming flu infection. So it can be quite effective, but what I'm saying is you need to it's obviously these things need to be taken on an individual basis and discussed with your provider, but the medication itself should be actually helpful.
And Dr. McGuire, as an add-on, are there any special concerns for mito patients with IVIG?
None that we've heard of. So this is something that we've actually been starting to study because, we're hearing more and more that individuals with mitochondrial disease are being put on immunoglobulin replacement therapy. And it's for a number of reasons, one of which is because they actually qualify as having immunodeficiency. Like that's one of the diagnostic criteria. You have to have primary immunodeficiency to receive immunoglobulin replacement therapy. And then there are individuals being put on for other reasons. So it's what we have heard is that individuals have been showing some benefits from that. But the one thing that is of concern when you are receiving immunoglobulin replacement therapy is that some individuals may have adverse reactions. So so the answer is it really depends on the individual. Some individuals actually can have allergic reactions to, or something called serum sickness to receiving immunoglobulin. So, and in which case they can receive pre-medication beforehand. So I do know of a number of patients who receive immunoglobulin replacement therapy and do quite well. And I have heard of a number of individuals who have, and it's not because of mitochondrial disease, it's just that their immune system just doesn't seem to like it, where they have adverse reactions and require things like Benadryl and stuff like that to help prevent having those adverse reactions. So people with mitochondrial disease are currently receiving it. It is not, so far the evidence that we have does not say that it is bad for them. Some may have adverse reactions, but that is not due to mitochondrial disease. There are other individuals who don't have mitochondrial disease who also have adverse reactions. So
that makes sense.
it's a story that's still evolving, actually, that we're looking into.
All right. Well, this is tangentially related. I know that we're talking about children and mitochondrial disease, but as an adult who potentially has mito and donated plasma in college, I'm wondering about the effects it potentially could have had on my body. Are there any studies or any potential benefits of plasma donation to children with mito, which we just talked about? What about plasma donation? Is that something that mito patients can do?
Meaning plasma donation in terms of, you mean for IVIG?
Well,
I'm not,
the way
yeah,
I'm
I'm not
reading
quite
this
sure.
is, they have the places where you can go and donate plasma, and it sounds like is this something that mito patients should be able to do?
Yeah, I mean, so I guess it depends. So if you have a healthy immune system, and you know that you don't have, any indicators of primary immunodeficiency or low levels of immunoglobulins, I mean, that's what you're kind of donating when you donate your plasma, right? You're donating antibodies in a liquid form, essentially. The antibodies are actually in the plasma. So in lieu of not having any problems with your immune system or any primary immunodeficiency or anything like that, there's no reason why not. Now, the question arises, what for an individual with mitochondrial disease, especially an adult, what are your stresses? In other words, what are the things that kind of, set you down a bad path? Is it giving large amount of blood? Is it giving, that's something that has to be kind of thought of on an individual level. But in terms of, if you have a healthy immune system and you have a healthy immune system, there is no reason why an adult with mitochondrial disease could not, in lieu of tolerance level, could donate.
All right. Here's an interesting question. And because you see mostly children, this may not apply to you, but you may know about this. Do people with mito have shingles more or less frequently than the average population?
Yeah, I don't know the answer to that, actually. So, but here's what I can tell you. So first of all, right, shingles is a reactivation of the varicella virus, which causes chickenpox, right? So varicella virus belongs to a family called the herpes viruses, right? So herpes viruses are things that cause like the cold sores on, so they're all within the same family. The thing about herpes viruses is they remain in our bodies for life, essentially, right? So, and that's what shingles is, essentially. It is the reactivation of the varicella virus, a type of herpes virus, within us. Tends to happen in older individuals, right? Because as it turns out, the half-life of your protective antibodies against varicella only lasts about 50 years, 40 to 50 years, somewhere in that area. So by the time, you hit 40 or 50, or you're above the age of 50, the half-life, in other words, your antibodies have decreased, significantly. So you need a booster. So we don't know the answer to that because we don't see adults. But here's what I can tell you. We published a paper a couple of years ago in kids looking at their protective antibodies against vaccine preventable diseases, right? So MMR, varicella, those kinds of things. The one, they were low in their antibody titers for a number of different viruses, but the one that was the greatest was varicella. So it turned out that 55% or 60% of our children that we surveyed, it was about 25 children, 55 to 60% were negative for protective antibodies against varicella. So I don't know in adults, but that does not, for individuals who truly have mitochondrial disease, that means that they're not starting out with a good pool of varicella antibodies. So by the time they reach, 50 or so, they could be at increased risk for shingles, but we don't have those data because we don't see adults. We only see children. But I can only comment on the protective antibodies in children, which they don't seem to have. Some children don't seem to have.
Oh, that makes sense. Here's a question I believe about the antivirals. Does
Yeah.
the antiviral suppress the virus? I've heard about rebound cases once they are done with the course of the antiviral in some people. So what have you seen with that with some of the people that you've worked with?
Right. So the antivirals are only as good as long as you take them. Right. So they focus on very specific parts of the replication cycle of the virus, right? So the one, for flu, for instance, right? First of all, it has to be taken within the first 2 days of having flu symptoms. Otherwise, it's not effective. And what it does is it actually blocks that interaction between the virus and the host cell at the receptor, basically, right? So the host cell has a receptor on the surface, which the virus binds to. So if you're taking the drug, it blocks that interaction. But it's only as good as long as you're taking the drug. So if you're, rebound cases don't, meaning if you get flu again, like it doesn't surprise me because the drug is only effective as long as you take it. Like it's not for extended periods of time.
All right, thank you. Would it be correct to say that mitochondrial disease patients might have a harder time fighting a virus, but might have a better immune memory of the viruses?
Well, so that was some of the data I actually showed. Their immune memory it looks like it may not be great. So what I mean by that is when a B cell gets activated, right, it becomes a plasma cell. A plasma cell is the factory for antibodies. That's what pumps out the antibodies into our blood to help protect us against viruses. When we looked at that in our patients, in other words, the antibodies that were being made by these cells, these plasma cells, which live in the bone marrow, by the way, the amount that they are actually pumping out was actually much lower in the children with mitochondrial disease versus controls. So that's an important part of immune memory, right? After you either see a virus or are vaccinated, these long-lived plasma cells in the bone marrow keep pumping out these antibodies to protect us. Turns out the kids with mitochondrial disease make less.
Makes sense. Okay, this one's interesting, and I hear this from time to time. I noticed when I become overly fatigued or when I overdo, I become more susceptible to a bacterial infection, especially something I normally would fight off when well rested. Is this something that is this something that you understand? And I just wonder what would be going on scientifically with the immune system when mitochondria are not functioning properly.
Yeah, so it's that complaint actually is not, or sorry, not complaint, but observation is not unique to mitochondrial disease. So, stress in general, can cause have negative effects on the immune system and its ability to fight infection. So it's not surprising that someone, if they have been either stressed or not getting much sleep or, various kind of things happening in their life, it's not surprising. The reason why this occurs is quite complex, but one of the things with stress is the secretion of steroids in the body, or corticosteroids in the body, as a result of stress. And unfortunately, those corticosteroids, what they do is they help, with various parts of metabolism and blood sugar and stuff like that. But one of the things that they do that's not so good is they actually suppress the immune system. So it's a normal kind of endocrinologic response to stress, but the unfortunate part is it actually suppresses the immune system. So it's not surprising when an individual experiences those types of things that they might be more susceptible to certain types of infections.
So we should all be as stress-free as possible.
Exercise, eat a good diet, try and control stress. I mean, stress is a part of life, right? It's unavoidable. But finding outlets to help control that stress can be very helpful.
Okay, now let me move on to the remaining. Oh, here's one that this would require a resource, but IMPDS. Do you have any resources available so that someone could learn more about that?
Oh, it's actually published. If you look up International Pediatric Mitochondrial Disease Scale, IPMDS, it's actually, so if you just look it up on the internet, that you should be able to find it. It's a scale that was developed specifically for children, to be able to kind of score their mitochondrial disease, for clinical reasons, for research reasons, So in other words, if the individual's disease either progressed or even got better with certain interventions, you had kind of a way of objectively scoring it, basically. So yeah, so it's available on the internet.
Perfect. All right. The most of the remaining questions that I have are surrounding COVID. So I'm kind of grouped them together. The first one I think I want to talk about is the this person had a COVID vaccine and had blood pressure changes. First dropped very low, higher. Is this something that that you've heard of before? And what would be the reason that the blood pressure would drop? I must say I did not write this question, but this actually happened to me too.
Yeah,
and it was severe, actually. And
yeah.
so wondered what it is. What happened to me?
Yeah, so normally, I mean, blood pressure issues normally you would see in older adults, and being that we follow mostly kids, first of all, I would say that we haven't really heard this. We have been monitoring adverse events from the COVID vaccine for a while now, in children. We haven't heard this in the pediatric population. In the adult population, we have heard, one or two stories of lightheadedness, basically, and feeling faint, and in which case, blood pressure dropping can be a part of that. I don't know the answer to that yet, but all I can say is that we have heard of a few cases of individuals having kind of that reaction to the vaccine. I'm just curious, was it something that happened immediately, or was something that happened within a certain amount of time? Or, sorry, your experience specifically?
Well, my experience was that it took a while, but it was lightheaded, exactly what you are explaining. And I got in the car and went to the local drugstore and took the blood pressure because I felt like that's what it was, and it was 78/30.
Yeah.
And then I would eat a bunch of salt and it would get better, and then it would go back down. I bought a cuff and kept it on, and it lasted for about 24 hours, and then I was fine.
So it occurred within minutes or hours?
Hours. It wasn't
within
right
hours. Away. Yeah. No, I don't know the answer to that, but certainly we've heard of a few cases, but in the pediatric population, we really haven't heard of any.
Now here's a complete question. A question I think is really interesting. What's known about the impact of ongoing and longer term effects of COVID-19 on the immune system and other systems for patients with mito? And what are some steps that people can take to mitigate those?
Yeah, so just to jump to the last part of the question first, some of the things we mentioned before about, diet and exercise and stuff that you would normally do to just maintain health, obviously within reason, right? Because certain mitochondrial disease individuals with mitochondrial disease have limitations with some of the stuff that they can do. So but one of the things, the viruses like COVID, as well as a lot of other viruses. So now I'm addressing kind of some of the long-term, effects and some of the effects it can have on the immune system. The thing about viruses is they have developed a lot of mechanisms for kind of evading the immune system or doing funny things to the immune system. We don't understand yet in mitochondrial disease specifically what kind of some of the long-term effects are, but we have heard in individuals, not specifically mitochondrial disease, but long COVID, right? And some of those symptoms they seem to be primarily neurologic. They seem to be so COVID seems to be able to get into the brain. There was a paper that was published by a group actually at NIH who looked at postmortem brains, essentially, from individuals who have passed away, and we're able to detect COVID in the brains of these individuals. So it does seem to be able to get into the brain. It it does seem to be associated with this kind of cloudiness or fogginess or inability to concentrate. We don't know yet in the mitochondrial disease community kind of what these long-term effects may be. It is, I would imagine it's still, possible for individuals with mitochondrial disease to have some similar symptoms, but we don't know yet what the kind of, because obviously individuals with mitochondrial disease, especially the younger kids, tend to have a lot of CNS disease. So we don't yet understand what that interaction is, but we have seen, as I mentioned, in individuals without mitochondrial disease, these kind of long COVID symptoms, which I don't know, would they be exacerbated in children with mitochondrial disease or even adults? We don't know yet. So sorry, that was a long answer.
Well,
just
that's
to say
a good
we don't
answer.
know.
I mean, it is that you're looking into it, and we'll eventually science will reveal to us the answer to that. Related, would you still recommend masking in public places, or is constantly wearing a mask weakening our immune system? So two-pronged question.
Yeah, so the mask is not weakening our immune system. And as far as wearing it in public, I mean, outside, so the virus doesn't survive very well outside, right? So meaning outside, like in nature. So it's not very resistant to heat or cold. The sun actually destroys, the RNA. So it doesn't survive very well. So, once again, if you're outside, and you're not around large groups of individuals and things like that, it would be okay to unmask and get fresh air and stuff like that. The times when you have concerns are in large groups of people, right? Or being inside, where a lot of times you'll have air that's actually recirculating. So it's something that people are doing less and less now, right, in terms of masking. And it really kind of depends. What I would say is I would do a self-assessment. So in other words, when I do get viral infections, what happens to me? Am I someone who winds up in the hospital, or I'm someone who just doesn't, feel well, for a couple of days, and then I do generally well? I mean, there's a lot of, I think, factors that go into this, figuring out, should I wear a mask or not? But I mean, I would still say for an individual who has mitochondrial disease who has a history of, not doing well with infections, I would say yes, in large groups and inside. And to be honest, most doctors' offices today still persist with their mask policy as well. So, it's not a bad idea in certain situations.
That makes sense. Two quick questions. Is there an adult IPMDS scale?
There is, and I think the IPMDS was developed from an adult scale, but it's kind of not in my brain at the moment, but I do believe there is one for kind of grading the severity of mitochondrial disease in the adult.
All right, and last question. I think this is a quick one. You mentioned the most common viral infection in the study done was enterovirus B.
Yeah.
Is Coxsackie type B considered under that umbrella?
Yes, yeah. So enterovirus covers like a really kind of broad category, and Coxsackie is one of the enteroviruses. Yeah.
All right. Well, that was a marathon, but we made it through all the questions. Thank you, Dr. McGuire, for being willing to hang out and answer those questions. I'm sure that this webcast will be very useful for those who are not on the call today to learn about this. It will definitely be enduring material. And I saw someone ask the question, this has been recorded and will be available on our website in a few days. So you will be able to watch it again. Somebody said they wanted to watch it again. So again,
wow, that is dedication.
Well, thank you, Dr. McGuire. We really appreciate your help now and always. And lots of great information tonight.
Thank you, everyone. I really appreciate it.
Have a